is Dr. Jonathan Huntley, Associate Professor at the University of Exeter and Consultant Old Age Psychiatrist. His research focuses on the cognitive and behavioral symptoms of dementia, with a particular interest in insight, awareness, and the neuropsychiatric features of Alzheimer's disease and related disorders. Please join me in welcoming Jonathan Huntley. Thank you.
Hi, and thank you so much for inviting me to speak. So I'm John Huntley, an Associate Professor and Old Age Psychiatrist based in Exeter, at the University of Exeter and at UCL. And I'm going to talk to you about some work looking at how we might assess awareness in Alzheimer's disease, both at the earlier stages, but I'm particularly interested in the more advanced stages. And it starts really from clinical work, and I'm sure many of you have loved ones who unfortunately have got dementia, have got Alzheimer's disease. And a lady in the study is ML, so this isn't a picture of her, but she's an 85-year-old Turkish lady who lives in a care home. So her daughter visits her about once a week, but her daughter says it's been at least a year, probably two, since she thinks her mother has recognised her in any meaningful way, doesn't really seem to be aware at all if she's there, if she visits. But she thinks her mum seems relatively happy, so she's mobile, she walks around the care home, and although she can't engage in any meaningful conversation, there is still some verbalisation. So she often does sort of sing-song nonsense phrases and spends quite a lot of time sitting in the communal area in the lounge, playing with her fiddle cushion, which she seems to enjoy. But the key question for her daughter, for the carers, is what on earth is it like to be her? So is she aware where she is, of who she is? When her daughter comes to visit, is she aware of her? And does anything make a difference? So she seems content with the fiddle cushion, but what's her sort of inner world? What's her actual experience? And this isn't a sort of a theoretical question. It's profoundly important for person-centered care. So as you'll all be aware, the drive towards person-centered care is crucial, particularly in advanced dementia. But how can we do person-centered care if we don't know what it's like to be that person? And there's really very little empirical data on this. We're sort of reliant on clinician judgment, on carers and for loved ones who know the person well to make judgments. But unfortunately, that can be unreliable. So there's been some work by Linda Clare showing that actually carers, particularly overworked carers in care homes, may just make judgments that this person is not aware of anything. And that can have impacts on care. So part of this project is to see, are there ways that we can provide some kind of insight and window into the experience of people with dementia? And what we ideally need is no report measures. So normally we ask people, what are you experiencing? What are you aware of? And they tell us. So it's inherently a subjective experience, and we can ask people about it. But that obviously becomes much more challenging in people whose language and cognitive function has deteriorated, so they can't really communicate their experiences and needs. And over the last few years, I've done some work with others, including Daniel McGraby, who's going to speak later, trying to look at what are the various aspects of awareness, the objects of awareness, the facets that seem to be affected by Alzheimer's disease in particular, and how these might change with disease progression. So there's a reasonable amount of work looking at the very mild stages, and we know clinically that insight into awareness, so anosognosia, insight into cognitive problems, metacognitive difficulties occurs really quite early on in Alzheimer's disease. And the richness of our episodic memory also seems to be eroded at the relatively early stages of Alzheimer's disease. But it remains an open question, how and if this progresses. So is it that actually with disease progression, this higher level, or what could be referred to as access consciousness, might become degraded, might deteriorate, but there remains some lower level consciousness, lower level awareness, sensory registration, perhaps a form of phenomenal consciousness. And does that persist? And these remain very open questions. One way that we're trying to look at this is taking approaches, paradigms, and markers from looking at other clinical groups, particularly from people with disorders of consciousness, and as we'll come to see in infants, so people who can't give verbal reports, and using some of these passive paradigms, applying them to people with Alzheimer's disease and looking at, is there a change in these biomarkers, and can it start to tell us anything about the phenomenology? So what are these main approaches? This project has looked at a range of approaches, including TMS-EEG, looking at complexity. I'm going to talk a little bit today about event-related potentials, and also fMRI studies looking at paradigms where visible compared to subliminal faces, for example, are shown, or movies, and also very briefly touch upon some work using devices that could be used more realistically in care homes, in homes, and so on, looking at remote access. And this is one potential option for this that can be used to measure level of arousal or arousal level of consciousness rather than the contents, but may provide some insight into how that might fluctuate. So the research questions really are markers of visual awareness reduced in Alzheimer's disease? So I'm going to present a couple of small studies, they're pilot studies, taking some approaches used, as I say, in other disorders of consciousness to look at, can EEG and fMRI data be collected? Can they be collected particularly from people with very severe Alzheimer's disease? And in response to some visual stimuli, are some of the ERP signatures of visual awareness, so the visual awareness negativity, the P400, reduced in Alzheimer's disease? Is there fMRI evidence of activity that goes beyond some of these visual areas and activates a frontoparietal network, which has been inferred to represent that higher level awareness? And do we see that in Alzheimer's disease? So as I say, there's a number of small studies involving 28 controls, so healthy controls without dementia, 17 mild to moderate people with Alzheimer's disease, and a small number of people with very severe Alzheimer's disease. So look at the Global Deterioration Rating Scale, which again is an observational scale, which describes the level of severity. The severe patients are right at the far end. So these are people who are, all of them apart from one was non-verbal, who can't engage with any other real cognitive assessment. So the first task that we used actually is taken from a study by Sid Kuder and colleagues that was published about 10 years ago now. And this was an approach looking at how visual awareness seems to emerge in the first year of a baby's life. So again, it's a passive paradigm using a masking visual awareness paradigm. So these approaches have been used now for decades to contrast visual stimuli that can be consciously experienced compared to visually stimuli that can't. So essentially, again, many studies have showed that if you flash up, for example, a face, if you flash it up for more than 100 milliseconds, then it'd be consciously experienced. But less than that, it's not. It's subliminal. It's not consciously experienced. So we can use this contrast to examine awareness by looking in an ERP paradigm across occipital parietal electrodes and looking for these components that have been associated with awareness, particularly this early posterior negativity, or the visual awareness negativity, and then again, we're still posterior, the P400. We also want to look at whether or not there's evidence of this ignition of frontoparietal areas. So there's lots of ongoing debate, lots of theories of consciousness, lots of potential neurocorrelates of consciousness, but one of the features associated with theories such as the global neural workspace theory is that actually for consciousness to occur, you need activity in the sensory cortex, but also this ignition of a frontoparietal network, particularly for access consciousness. So we use this paradigm in both an EEG and fMRI experiments. So for the EEG, we use 10 blocks of 20 trials, for fMRI, 3 blocks of 60, with these 4 conditions, looking at faces and masks at either a subliminal, 3 milliseconds, or a visible 200 millisecond duration. And the main contrast we're interested in is this visible minus the subliminal face. But the first thing I'm just going to show is the grand averages of these event-related potentials across groups and across these occipital parietal electrodes. And as you can see, the top are the controls, the middle are the mild to moderate. And both the controls and the mild to moderate show sort of evidence or components of early visual processing, and then an early negativity. And the posterior, for the visible faces, is reduced in the Alzheimer's patients. The severe, you can see there's really not very much evidence of components at all to any of these conditions. And if we look at the component of interest, so looking at the visible minus the subliminal, again, we can see that the healthy controls have got very clear visual awareness negativity in P400, and both of these components are reduced in the mild to moderate group. Again, given what we've just seen, it's not surprising that they're not present in severe. And this is clearly an issue because we cannot then interpret this as a deficit in awareness. May well be just a lack of sensitivity to the task or a heterogeneity in such a small number of participants, as we'll come to see. But these components do correlate significantly with disease severity. And also looking at more frontal electrodes, we can see that frontal components are also reduced, sort of including, for example, the N400. But this is associated more with downstream processing, so downstream processing of conscious contents rather than being a marker of awareness per se. If we move to the fMRI, so again, a same paradigm, unfortunately even fewer patients for this. So this work in particularly people with severe dementia has been very challenging, really due to tolerance, contraindications, and so on. So the main analyses I'm going to present are comparing the group between controls and mild to moderate, and we'll just look at some of the severe patients as a case series. And we conducted both univariate and then multivariate pattern analysis, where we're looking particularly for evidence both of visual cortex activity, but also this activation of frontoparietal network. And just to look at sensitivity to task, so just looking at the main faces contrast, not the awareness contrast, but faces, we can see that faces do evoke widespread expected responses in both groups, so across fusiform and prefrontal regions. But the real contrast of interest is comparing, again, these visible and subliminal faces. And we can see, so this is the multivariate pattern analysis results, but it echoes what was found in the univariate analysis. That within the controls, we see expected activation within both visual areas and also frontoparietal activity. This is present but much reduced in the Alzheimer's patients. So that's the middle panel, and the bottom is comparing the two. And we find that particularly it's this frontoparietal region that is more activated than in controls than in the Alzheimer's patients. Looking as a case series, again, this is very small numbers. We can't make any strong interpretations, unfortunately, from this. But it's interesting to note that in a single patient case series, only one of the four, again, looking at this contrast of visible compared to subliminal, showed evidence of awareness-related activity. This was that somebody who was, of the severe patients, the least severe. So it was 6 on the global deterioration scale rather than 7. So in summary, using this paradigm across both EEG and fMRI, it does look like comparing the controls with the mild to moderate group, there is a reduction in both the visual awareness negativity and in the P400 and in some of the frontal components. And on fMRI, we see less amplification of visual areas and a reduced frontoparietal activation. In severe dementia, I say it's difficult to interpret. It may represent a lack of experience or awareness of the stimuli. However, there is almost certainly a lack of sensitivity to the task, as well as heterogeneity between the patients, and also, as we'll come to look at, potentially fluctuations of arousal that all play a role. So how about something a bit more engaging? So that's sort of a more a faces task where it's just flashing faces. This is an approach using a film a movie task that some of you might be aware of called Bang Bang You're Dead. So this is an Alfred Hitchcock film, 8-minute film. It's engaging because watching it, you know that this little boy has found his uncle's gun and it's loaded. He thinks it's a toy, you know it's not. So it's quite a tense Alfred Hitchcock film. And the whole paradigm was developed by Adrian Owen and colleagues to look for evidence of covert awareness in people in minimally conscious states. So in their work, what they did is demonstrated that you can look at various components, but particularly interested in frontoparietal networks. And the key to this is that when you or I watch this movie, actually our frontoparietal activity and our visual cortex activity behaves the same. So it synchronizes across individuals. So you can look, therefore, at individual people and how they might behave, and if that deviates from how the group would normally behave in terms of synchronicity. And again, Adrian and colleagues demonstrated this in individual subjects with disorders of consciousness, essentially looking for evidence of a lack of synchronization of that frontoparietal network, which was interpreted as demonstrating a lack of higher level awareness and engagement with the movie. So we conducted this, again, in the same number of participants as the FACES task, and what we're looking for, as in the Owen papers, is evidence of this frontoparietal synchrony, so this marker of higher level engagement and awareness. And the way you do that is just simply look at the correlation between individuals, the inter-subject correlation of the time series as people are watching the movie. So the panel at the top A is just demonstrating that, as in the previous studies, we found with our healthy controls, people are behaving the same. Essentially, there's synchrony across, also within the group, healthy controls across a wide range of sensory and frontoparietal regions. Panel B, just looking at the Alzheimer's patients, how well they synchronize with each other. The answer is there is synchrony, but it's largely restricted to posterior regions. So there seems to be a loss of frontal parietal synchrony within the Alzheimer's group. But perhaps more interestingly is comparing the two to get a sense of how this might change with Alzheimer's compared to controls. We can look at the synchrony between individual people with Alzheimer's disease with the response of the controls. And we find that actually it's mostly, again, auditory and visual synchrony with the control group, with some frontoparietal, but much reduced. Looking at those 4 severe patients again, the same participant who did show some activation with the FACES task did show some visual and auditory synchrony with the control group, but no frontoparietal synchrony. And the others didn't show any synchrony patterns. Again, there's activity there, but it just wasn't synchronizing. So just going back to the sort of research questions for some of this pilot work using these paradigms. So is it possible to collect this data in severe AD? It is possible. It's challenging. Some of this work was done during COVID a few years ago now, which made it even more challenging. The question then, in response to visual stimuli, are these ERP signatures, so the visual awareness negativity to P400, reduced? They do appear to be significantly reduced in mild to moderate AD. And we also seem to see this reduction in frontoparietal activation and synchrony in the mild to moderate group, with, as I said, already said, a lack of that activity in the severe patients, which is challenging to interpret given it may reflect a lack of sensitivity to task or fluctuation of arousal. And that's something that we've tried to expand and look at in a much more real-world setting. So what would be ideal is to have ways of measuring changes in awareness, changes in arousal in a real-world care home setting that could even potentially provide that information to carers to use. So we've been looking at a range of remote wireless devices, including wireless EEG, physiological measures, and so on, trying to correlate that with some of the behavioural measures, of which there are really very few. So we've been looking at Aware Care that was developed by Linda Clare, but there are really not very many tools that are designed to try and assess awareness in people with very severe dementia. And I'm just going to end with again, it's a very simple slide, but this is just evidence from our use of BIS. So bispectral index measuring is an EEG marker that I'm sure you're all familiar with. It's being used all over the world every day in anesthesia. It's essentially a blunt tool to measure level of consciousness. So it's not telling us anything about content, it's simply talking about level of arousal. But it is portable and we can use it. And again, there's been very little work looking at this in people with, for example, advanced dementia. But what's interesting is this is some data from 20 people in care homes, in their room in a care home. All of them have got very severe Alzheimer's disease. All of them were sitting with their eyes open at rest for the entire duration of time, which was around 14 minutes average. But I think what's just striking is that we still get a very, very wide range of values on the BIS. And the norms are, and the reference rates are put to the side. So healthy people, when they're awake, are between 80 and 100, and that's reduced down. So for the anaesthetist, for the surgeons, once you're getting down to 40 or 60, you can start your operation. So it's interesting how much variability there is here between and within participants. which again is something that we're hoping to go on and explore more and ask interesting questions about just this fluctuation in arousal, which is highly likely to also play a part in some of the results of when we're looking at the content of awareness. So this work trying to apply some of these markers from other clinical conditions, I think, opens up a lot of questions and a lot of potential avenues for research. So these questions of, well, how much does arousal and awareness fluctuate and advance? How much does it vary between and within individuals? And just pointing to the point at the end there are these really fascinating reports of lucidity that carers, family members will say there's this episode of increased awareness. Again, that's not really been systematically identified or catalogued, and it would be really good if we could try and combine some of that, if we could capture this with looking what might be happening neurophysiologically or physiologically. But the next step really is to try and look at these more longitudinally with disease progression within the same individuals with some subjective reports at the initial stages and then track how they might progress. Also, the question is, we can see that actually perhaps that faces paradigm is not necessarily very sensitive, or there was some insensitivity to task. Are there other modalities that would be better? So other modalities that actually may be more salient, more important for people at the advanced stages who have got sort of visual inattentive deficits. So sound, touch, smell, something, these are all areas to explore. And as I say, using less invasive, less challenging methods in the real world, so in wireless systems as well. And finally, it would be really interesting to look at different subtypes of dementia. So to look at how these fluctuations in awareness, look how these biomarkers may differ in, for example, Lewy body dementia or frontotemporal dementia, and also as the disease progresses. So thank you very much. Lots of people to thank at UCL, and thanks to the welcome. But thank you very much.
Thank you, Dr. Huntley, for a fantastic talk. To keep to time, I think there's time for 2 questions. Yes, Quentin.
Do I need a mic or?
I can hear you. Yeah.
Go ahead.
Thank you. Brilliant talk. So I'm just wondering, you're talking about awareness here. I'm just interested in the idea of whether awareness here essentially accounts for a kind of perceptual salience, and the relationship between the awareness that you're measuring and the neural markers of that, and what we might call self-awareness. So, the self is a centre of narrative, gravity, default mode networks involvement, and so on. Because I'm just wondering whether in Alzheimer's the capacity to sort of associatively elaborate the interpretation of experience becomes diminished. Whether you see a dissociation with this perceptual awareness and this more enriched self-reflexive awareness.
Yeah, so that's absolutely fascinating. And so unfortunately, we didn't collect resting state to look at default mode network and so on. And actually that is, for me, the more interesting question, is how is that more internal, rich, reflective consciousness impacted? So this data can't speak to that. And I think that one of the things that could do is collecting richer subjective narratives from people with Alzheimer's disease at the earlier stages and while they can still verbally communicate and capture whether that shrinks, if you like. There has been some work on that which suggests that, for example, autobiographical memories decline and the richness of that does decline. But I think that, that's a very important area of work.
Okay. Yes, gentleman at the back.
Thank you. I think the first question is partly asked if you could use the resting state and look back, because I'm wondering if you can dissect out what's arousal and what's attention and what's awareness, as you said, both internal and external. Yeah. I don't know whether you did any sort of more mundane things that you probably did, things like eye movements. Were they actually attending? Because we all know it gets harder to fixate.
Yeah. So we tried very hard to control for that. So we used infrared monitoring of gaze. So, for example, in the scanner to ensure that their eyes were open, that they were fixed at the stimuli. And similarly, when we were doing the EEG, we were able to capture that. So we tried to control for those kind of external attentive factors as best we could. I think it's an again, a fascinating and ongoing question of how does attention and awareness, where do they overlap, where might they dissociate? And I think particularly stepping back from what is this like for the patient, what is it like for the person with advanced dementia, the end result is that they're not experiencing, for example, a perception, or they're not experiencing it, whether that's due to an attentional deficit, an awareness of how they overlap, I think is really useful. It would be really important to try and dissociate, but actually, again, at this stage, we're just trying to get a sense of what's possible, what is the capacity here, and then trying to fractionate that down and looking at how they might, it might dissociate between more traditional attentional type of assessments. Yeah.
Wonderful. Thank you.
Okay. Right, thank you.